Welcome again, and now we will be talking about the pituitary gland. First of all, in this video, we will cover its anatomy. Then we will study its various pathologies and the various pharmacology and treatment, its medical as well as surgical treatment. So all will be discussed. So in short, the whole pituitary gland will be discussed. First of all, its anatomy. So the pituitary gland is a small oval shaped small gland. So and it is located. It is a small gland which is attached to the lower surface of the brain via infundibulum. Infundibulum is its stalk with which it is attached to the brain. So that is why it is called as hypophysis cerebri. The pituitary gland is also known as hypophysis cerebri because of that. You can see over here that if this is the brain, the whole brain lies above it. So this whole is your brain, and it is attached. It is present at the below the brain, and it is attached to the brain via a stalk, which is also called as infundibulum. Okay, so there you have all of it. Now it is attached to the base of the brain via infundibulum, and it lies in the Sella Turcica. Sella Turcica is actually a small depression which is present in the sphenoid bone. So a small depression in the sphenoid bone, here you can see it. This is your sphenoid bone, and a small depression in it over here. So this is your Sella Turcica. So it lies in the Sella Turcica, okay, which is a depression in the sphenoid bone, and it is covered by diaphragmatic sella. Diaphragmatic sella is actually an extension of the dura mater that is present over this depressed area of the sphenoid. Okay, so the diaphragmatic sella covers this depression over here. We know the dura mater is the membrane of the brain. So as it covers the whole brain over here and here, so it forms an extension that lies over this depressed area, and this extension is called as diaphragmatic sella. So your pituitary gland is covered at the top by the diaphragmatic sella. Okay, here we go. Now the gland is divided into anterior and posterior lobe. So this gland has anterior and posterior lobe. The anterior lobe, or the adenohypophysis. Adeno, you know about the gland. So it is mainly the anterior gland that is the gland. The posterior lobe is more of a storage site. That is not mainly not a gland itself, because it does not secrete any hormones itself. We will see it shortly. But first, the anterior gland, that is a which is again divided into the pars anterioris and pars posteriorus. Okay, so this is the main gland, and it comprises of about 80% of the gland, and it produces 7 different type of hormones: TSH, ACTH, LH, FSH, prolactin, beta endorphin, and growth hormone. So all these hormones are produced by the anterior pituitary. And there is it is again divided into pars anterioris and pars posteriorus. Not do not go into such a detail, but just remember that the uh, pituitary gland has two lobes, and sometimes a small projection of it that is called as pars tuberellus. Just remember this. You can see over here, this is the anterior lobe of the pituitary lying over here, and this is the posterior lobe of the pituitary, and this is the pars tuberellus, the small elevation you can see. So this small elevation is called as pars tuberellus. Okay, so anterior lobe, posterior lobe, and we have a small elevation that is called as pars tuberellus. And the posterior lobe, or the neurohypophysis, the neurohypophysis, it is more of a storage site. It is a storage site for the hormones that is produced by the hypothalamus. So basically these hormones are produced by the hypothalamus, and then via axons it reaches the posterior pituitary. So the posterior pituitary is mainly not a gland itself, but it is a storage site for the hormones that are produced by the supraoptic and paraventricular nuclei of the hypothalamus, and it is then stored in the posterior pituitary, and it produces oxytocin and antidiuretic hormone. We will study each of these hormones in details in the upcoming videos. Now, first of all, now we will talk about the various relations, so that you know that what lies ahead of it, what lies behind it, and well, mostly it is very important in the surgical, if you're looking at the pituitary in a surgical point of view. So anteriorly you have sphenoid sinus over here, if I can show you. over here you can see in this figure number 2, you can see that this is the gland and lying anterior to it is sphenoid sinus. This blackish area that you can see, so this is your sphenoid sinus. Okay, posteriorly is the dorsum sella. So what is dorsum sella? It is actually a square shaped area of the sphenoid anterior to the clivus. You can see this, you can see it in figure number 1, 2 and 5. So in the 1 it is not so properly shown, but in the 2 you can see. So this is your pituitary lying over here, and then there is a square shaped area, this square shaped area over here lying over here. So this is called as your, this square shaped area at the top, so this is called as your dorsum sella, and behind the dorsum sella is the clivus. This is the downward projection, so this downward going area, that is called as clivus, that then opens at the foramen magnum. Okay, so this dorsum sella lies just anterior to the clivus, and the posterior to that is the basilar artery and pons. You can see this is the basilar artery, and then behind it is the brainstem and pons mainly. So pons is located posteriorly. Then what lies superior to it? We know that superiorly the dorsum sella covers it, and moreover the optic chiasma is also present superior anteriorly. You can see over here, so this is the gland, and superior to it, this is covered over here and here by the diaphragmatic sella, and lying above it superior anteriorly lies your optic chiasma. Now the optic chiasma is you know, the optic tract and optic chiasma, it is where the nasal fiber decussate. So as a result, what happens that whenever there is a tumor of the pituitary gland, will cause its compression, and it will lead to the bitemporal hymenopsia. We will see it in further details in the pituitary tumors, but just remember that this optic chiasma lying over here, so once the pituitary tumor arises, so it will start expanding, and what will happen that this optic chiasma will get compressed, and it will then show the bitemporal hymenopsia. Okay, now moving further ahead, and now we have inferiorly you have body of sphenoid. We can see it over here, that this over here you can see that inferiorly you will have body of sphenoid as well as the cavity of the nose. So body of the sphenoid and cavity of the nose inferiorly. What lies laterally? Now the laterally we have cavernous sinus. You can see this is your pituitary lying over here, and lateral to it is your cavernous sinus. This is your cavernous sinus lying lateral to it. Now the cavernous sinus contains various structures, and you have to remember these structures. It contains internal carotid artery, then you have the maxillary nerve, and you have V1 and V2, ophthalmic division and maxillary, ophthalmic nerve and maxillary nerve. So these are from the trigeminal nerve. The trigeminal nerve have 3 division, and 2 of it is are passing through the cavernous sinus. Moreover, you have trochlear nerve and oculomotor nerve also passing in the wall of the cavernous sinus. So you have to remember these, and a cool way to remember is nerve 3, 4 and 5th, V1 and V2 of the 5th as well as 6th nerve. So all these nerves are passing through the cavernous sinus. So the oculomotor, trochlear, abducent, ophthalmic and maxillary division of trigeminal nerve. So all these nerves pass through the cavernous sinus. So what will happen is that if there is any compression caused by the pituitary, so it will cause deterioration of these nerves, and you will see the nerve palsies of these nerves. So that is all about the anatomy of the pituitary gland.